Okay, so welcome to the Peer Health Educator Training Program. This program was developed by the Office of Minority Health Resource Center. So we can get started. So first what we'll do is we'll do a pre-test. Gabby's gonna send it out into the chat and just take a few minutes, no rush. Don't worry if you don't know all the answers. You'll have a chance to retake the same test at the end of the training, well, which will be next Tuesday. Um, and once we've gone through all of our talking points, you'll be able to answer all the questions. This is just a way to gauge how much you know now and to measure how much you've learned by the end of the training, which will be next Tuesday. So just a few key facts. The U.S. has higher rates of infant mortality than any other wealthy country in the world. For every 1,000 babies born in the U.S. each year, 11.4 African American babies die before their first birthday. And African American infants are more than twice as likely to die during the first year of life than infants born to white mothers. College-educated African American women have worse birth outcomes than white women without a high school diploma. The health status of immigrant groups declines the longer they live in the United States. And so during our training, we'll address why do these health disparities exist and what can be done to make a difference. So just like a history of PHE or Peer Health Educators, in 1985, the Secretary's Task Force report on Black and minority health, also known as the Heckler Report, was released, which documented and validated the existence of such health disparities among racial and ethnic minorities. The Office of Minority Health was created a year later to address these disparities with the mission to improve the health of racial and ethnic minority populations through the development of health policies and programs that will eliminate health disparities. Then the Office of Minority Health Resource Center was created in 1987 and is an established source for minority health literature, research, and referrals for consumers, community organizations, and health professionals. And then following right along, in 2007, the PHE program was initiated by the Office of Minority Health, OMH, as part of a Healthy Baby Begins With You campaign to address health disparities within minority communities. And the PHE program has expanded to 30 college campuses across the US. And just an additional note, in 2020, Momnibus was passed to also address these these disparities. So that's just like a big up that will probably be on the next slide, probably next year. All right, so the Peer Health Training Program, the purpose of the training is to identify outside factors that cause health disparities, that specifically infant mortality or the death of children younger than 1 year old. To train peer health educators to promote behaviors that will improve health among their peers today and reduce infant and maternal mortality in the future. So just a heads up, we will be covering some sensitive subjects today, but be respectful of your own personal boundaries and the boundaries of others, as each of us chooses whether we want to share personal experiences and to what degree. We really won't be sharing many experiences today, but there will be some sensitive subjects, so just let us know if you need to take a break or just. Here are some key terms that we'll be going over. This is a list of key terms that you'll learn as part of your PHE training. Don't feel like you have to absorb all of them right now. We'll cover them one by one throughout the training. All right, so module 1, peer education. So the module objectives are to understand the benefits of peer education, to understand the role of an OMHRC peer health educator, to learn to communicate with your peers, and to learn the requirements to become an OMHRC peer health educator. So the peer education model, research shows us that people are more likely to accept information and thus change their attitudes and beliefs if they feel like the messenger is like them or has gone through the same life experiences. So what is peer health education? Peer education is a teaching or co-teaching relationship between people who are in some way equals. Peer educators and learners share some degree of common experiences and desire to help and learn from one another. Also, peer education is based on the assumption that learners are often likely to relate and trust others in their own circumstances more than professionals who experience might be entirely different from theirs. We can go to the next slide now. So, some key traits of peer health educators. First, we'll start with transparency, which is the ability to show true personality and passion rather than just putting up walls for your peers. The next trait is confidence in both your comprehension of the message and in your ability to deliver it. This will help build credibility among peers. Then we have conviction, having a strong vision and the drive to accomplish sought after goals, not just talking the talk, but walking the walk. This will motivate others to join. Next, we have innovation, thinking outside the box, creating new methods to solve problems and maintain interest in the program. Then we have empathy, the ability to understand others' emotions, where they're coming from, without comparing experiences to validate what they are feeling. And last, we have flexibility, being open to new ideas, change, and mishaps that should occur during your leadership journey. So this slide will talk about how to communicate on the topic. Um, Active listening, storytelling, and public speaking. Starting with active listening, it's the method to build understanding, trust, and a relationship with the audience. Peer educators are able to show empathy and support to a peer by asking open-ended questions, validating what they say, and reflecting on the peer's feelings. Next, we have storytelling. This breaks down barriers by revealing your own vulnerabilities and strengths, reinforces peer-to-peer connection that can be crucial for peer education, allows peer educators to model healthy behavior without being too preachy, gives peer educators the power to influence positive behavior change in their audience. You can show it can be done. And last, we have public speaking. Knowing basics of public speaking can be crucial to communicating health messages and earning respect as a credible leader and teacher. Basic public speaking skills include not being afraid to show your personality, don't read off of a script, and use nonverbal communication. Good posture and a steady stance. Maintain eye contact, nod to show you that you're actively listening, and paying attention to the tone of your voice. So some details of the certification. Students who successfully complete the training and receive a score of 75 or above on the post-test given at the end of the training will be awarded a level 1 training certificate, and the post-test will happen next Tuesday. Students who do not achieve a score of 75 or above will be given 2 additional attempts to become certified. Students can earn a level 2 certification as a peer health educator after they have successfully completed training and scored a 75 or above on the PHE post-test, attend a minimum of 6 live or 8 archived webinar sessions. Students who view the archived webinars must provide proof of attendance by leaving their name and school name in the comment section, and participate in 1 recruitment event, 1 training event, 2 campus activities, one campus activity can be substituted for a community activity. A level 2 certified peer health educator can add their experiences and participation in the PHE campus program to their resumes. So Gabby will drop the quiz again in the chat, just kind of reviewing everything that we just went over.
All right. So thank you so much, Lauren, for taking us through Module 1. I'll be helping guide us through Module 2, which is about the social determinants of health. For this module, our learning objectives are understanding the social determinants of health, understanding the role of racism in health disparities, and also how racism affects the social determinants of health, and understanding the life course perspective. So on this slide, there's just a few key facts about health disparities. So for many health conditions, non-Hispanic Blacks bear a disproportionate burden of disease, injury, death, and disability. These disproportionate burdens are known as health disparities. African Americans in their 20s, 30s, and 40s are more likely to live with or die from health conditions that typically occur at older ages in whites, such as heart disease, stroke, and diabetes. And stress due to experiences of racism can contribute to adverse birth outcomes like infant mortality when combined with the effects of general and maternal stress. And infant mortality is defined as the death of a child before 1 year of age. So here on this slide is just a diagram I'm sure you've all seen before of the social determinants of health. These are the conditions in the places where people live, work, learn, and play, which affect a wide range of health risks and outcomes. And these conditions are known as the social determinants of health. So SDOH or social determinants of health are shaped by a wider set of forces like economics, social policies, and politics. And they also include everyday systems such as healthcare that are in place to handle everyday life, including both wellness and illness. Resources that enhance the quality of life in these areas can have a significant influence on population health outcomes. Addressing the social determinants of health is important for improving health disparities, especially within minority communities. So on this slide, I'm just going to open it up for discussion for anyone. Feel free to unmute yourself. But can you think of any examples of social determinants of health that might have affected the health of someone you know?
Poor living condition.
Oh, sorry, could you repeat? Did you say poor living conditions?
Mm-hmm.
Yeah, absolutely. That's definitely with the built environment, what's in our homes is so important to shaping what our health looks like, and is often very, very different. The quality of building materials and things in homes are disproportionately less quality in communities of color and low-income neighborhoods.
Education sometimes does, because the education of the mother determines how she, assimilates information and how she accesses services that are available. If she's not educated enough to know those services are available, then she does not access it, and that could, affect her or the child.
Absolutely. Yeah, thank you so much for explaining that. That we'll touch on that, an example of that too, I think in a couple of slides, but education has a huge effect on the other social determinants of health, like your access to resources and economic stability and so many things. So yeah, absolutely. All right. So on this next slide, we have a definition of racism from Harrell and Williams, and that is a pervasive system of race-based oppression manifested as skin color, hierarchies, prejudiced attitudes, unfair treatment, institutionalized barriers, and Eurocentric cultural models. So along with this definition of racism, there are the three types of racism. There's internalized, interpersonal, and institutional. And internalized racism is defined as conscious or subconscious acceptance of racist views, stereotypes, and biases of one's own ethnic group, which can in turn produce feelings of self-hate or invalidation. And interpersonal racism is the type of racism that people are the most familiar with. It occurs between individuals and involves holding negative attitudes toward a different race or culture, and often follows a victim-perpetrator model. And institutionalized racism is the systematic distribution of resources, power, and opportunity in our society to the benefit of people who are white, and then to the exclusion of people of color. So here, this is an example of how racism impacts the social determinants of health, and kind of tying in what we were talking about earlier with how education impacts so many other aspects of health, individual health. Just going through this graphic, an example of institutional racism would be low minority representation in government, which could manifest in economics and social policies with low funding for public schools and wealthier families attending private schools, which would typically be like white families, and benefit white communities. And then for the social determinants of health, this low funding for public schools and this kind of hierarchy can impact the quality of education, which then impacts employment and financial stability and access to healthcare, which can lead to chronic stress and lack of medical care, which really impacts the individual health. And then interpersonal and internalized racism are individual factors that directly impact individual health. So here are some examples of institutionalized barriers, and they're a result of institutional racism, discrimination, disparities that have occurred in employment, housing, education, healthcare, law enforcement, government, and many other sectors. But here we have the Flint lead crisis. I'm sure you're all pretty aware of what happened there, but this is an example of environmental racism, government not listening to communities of color when they're expressing what they need, and just the delay in giving this community that was predominantly Black and low income, denying them the access to clean water that they deserve. And inner city food deserts, which is a big problem in Philadelphia, and cities all over the country. this is just an example of the inequitable distribution of resources for just the adequate, healthy food that people need. And people are kind of left to having to buy their food from like a convenience store or a corner shop that doesn't have those conveniently provided healthier food options. And then lastly, mass incarceration. This is just such a pervasive problem in our country, and it's a cyclical process that's really hard to escape. And being incarcerated also affects your ability to have an education, get employment, so many of those factors that we discussed that contribute to your health. All right, and then for the second discussion question, have you ever had personal experiences with any of the 3 types of racism? And this doesn't necessarily have to be a personal experience either. You can also share an experience of somebody you know, or maybe examples from like projects or research you've done or jobs that you've had, or maybe observations during the pandemic, anything you feel like you want to share.
I'm sure a few of us have experienced interpersonal racism. Me, as in myself, I'll use myself as an example. Yes, personal racism, and it's open. So,
thank you for sharing that.
I definitely say that's something that we've seen this year and last year during the pandemic. You know, Black and Brown communities being disproportionately affected by COVID, even by accessibility to the vaccine early on. And so we see that just based on the principles we were talking about earlier, institutionalized racism and just systems that were built to oppose Black and Brown communities. And to keep them in poverty and cycles, and those cyclical cycles that you were talking about earlier. So I would definitely say that's a big example that we would see blatantly in this past year.
Absolutely, yeah. I think it's some of the research I'm doing right now. We're talking to caregivers of children and youth with special healthcare needs. And these are families in West Philly who go to St. Chris Hospital. And we are also doing like a home assessment with them. And it's very clear that the city doesn't really respond to them with urgency if their power has been out for a really long time, or if like there's an abandoned row home next to them and there's like problems with having rodents or like water damage or whatever might happen as a result of that. Like it's very clear from hearing them express their concerns that the city it just is not really like allocating the resources that they need to have better home environments, which is totally affecting their health. So that's something that I've kind of been hearing about and learning through that research. All right, we can go to the next slide. So next we'll be talking about the life course perspective. And this is just the theory that each life stage is influenced by the stages that precede it, and in turn influences the life stages that follow it. So experiences seldom happen in isolation, and many times they're ongoing and impacts health of individuals affected. So the life course perspective is more of a holistic view on health that focuses on the collective experience of somebody's life over their lifetime, rather than just looking at disease and illness in like a isolated perspective. So this graphic on this slide is just an example of the life course perspective, which is a very probable example in life, but it's starting from birth to adulthood. And this particular person was born preterm and faces health problems such as sleep apnea, resulting in developmental delays, and then in early childhood experiences poor nutrition and quality of daycare and lack of access to healthcare, further inhibiting physical and intellectual development. And then in childhood is enrolled in an underfunded school with a high teacher turnover, and their neighborhood has gun violence as a common occurrence, and their learning disabilities and behavioral problems go unaddressed. And then in adolescence, internalizing the stigma surrounding her life, she numbs her emotions with drugs and alcohol use. Lack of access to sexual health education and resources leads to pregnancy before the age of 18. And then in adulthood, as a single mother, struggling to finish high school and hold down a job, living paycheck to paycheck. And then in turn, her child is also suffering from poor nutrition, poor quality daycare, and a lack of access to healthcare. So the life course perspective applies the understanding of long-term health effects of the social determinants of health, and how this conceptual framework also shows that it's a cyclical thing that passes from one generation to another. So it can help explain disease patterns across populations over time. And then instead of focusing on differences of health patterns for one disease or condition at a time, it points to broad social, economic, and environmental factors as underlying causes or the root causes for persistent inequalities. All right, we can go to the next slide. So next we'll be talking about how stress comes into play with all of this. And this is a quote by Opal Palmer Adisa, and she's a Jamaican writer. She's also a university director and a professor. And this quote reads, "Stress is hemmed into our dresses, pressed into our hair, mixed into our perfume, and painted on our fingers. Stress from being an African-American woman in white America. How long do you think you can hold your breath without asphyxiating?" So this quote just shows how like all-consuming and present stress is for African-American women, especially in our society in white America. So in 2008, a study of 51 African Americans and 73 non-Hispanic whites, lifetime and childhood indicators of perceived racism predicted birth weight. And models within each race group showed that perceived racism was a significant predictor of birth weight in African Americans, but not in Hispanic whites. So here with early programming or early life experiences, early programming influences your health and function throughout the course of your life. And a mother's stress during pregnancy affects the health of the baby. So chronic stress leads to the hyperactive fight or flight response for the fetus, and the baby is now unable to properly react to stress as well. So this again is showing kind of the cyclical process of stress and the role of stress in the mother's and the baby's life. So next is epigenetics, and these are the factors that turn genes on or off, and stress has a huge role to play in this. And different combinations of genes that are turned on or off over the course of life are what make us unique. It's why some people have brown hair, why some people hate the taste of broccoli or are less sociable than others. So what you eat and where you live, who you talk to, how much sleep you get, all of these things and more can cause chemical modifications that turn genes on or off over time. And genes can also be switched into the opposite state or away from a health or normal state, which is what causes disease. So lots of factors can either help or harm an unborn child. For example, a mother smoking cigarettes can alter a baby's genes. A paternal obesity can impact a baby's growth. On the other hand, a mother eating a diet with high folic acid supplements can help lower child's risk of neural tube defects like autism. Epigenetics is also hereditary, which means environment and health behaviors can influence not just one child, but entire generations to come. So this slide is about allostasis and allostatic load. So regular allostasis is just the body's normal resting place or a normal body response to stress. So allostasis is the ability for the body to self-regulate. Like if you get scared and your heart rate rises really quickly, but then eventually falls when you know you're safe. But when somebody is faced with chronic stress, that ability to come back to regular allostasis is lost. So the body has a hard time shutting off the immune response. And this can lead to preterm birth and low birth weight, as well as chronic lifelong conditions. And then preterm birth, which is defined as occurring before 37 weeks of pregnancy, can result in a variety of long-term health-related issues for the newborn, such as asthma, neurological disorders, and infections, and more. So again, very cyclical, and the mother's stress load and experiences affect the baby's health significantly. So additional impacts of chronic stress, we've already talked about low birth weight, but hypertension and diabetes can also develop later on in life. And chronic stress can lead to unhealthy behaviors such as cigarette smoking, alcohol and substance abuse, improper nutrition, and refusal to seek medical services. It can also lead to mental health disorders, which are most prominent among racial and ethnic groups, such as Asian Americans and African Americans. There's also evidence that health impacts caused by stress the health implications of stress affect immigrants. Lauren already kind of touched on this earlier, but the health status of immigrants actually tends to decline over time when living in the US because of the chronic stress of an unfamiliar and unwelcoming environment, and lack of healthy food choices and discrimination and more. So there are ways to manage chronic stress, and some examples of managing chronic stress are having a supportive social network, having safe spaces created for yourself and your community, engaging in religious and spiritual practices, engaging in peaceful activism, and sharing personal experiences. And also limiting exposure to cues of racism as much as is possible. And an example of that would be on social media, just being able to control whose content you're seeing and who you're interacting with. And then physical activity. So our next slide, our last discussion question for this module is, in what ways does stress impact your life, and what are ways that you've learned to cope with it? And you can choose to share just your coping strategies. You don't have to talk about how the different ways you're stressed out, if that might stress you out more than you already are. But yeah, just feel free to unmute yourself and share if you like.
Hi, I guess I'll share. I think one of my most beneficial kind of like coping mechanisms for stress is like staying active, especially with the pandemic. I joined I guess like a fitness group kind of, instead of going to the gym, and a lot of the women, it's pretty like focused on just like a women's group, but a lot of them are pregnant women, and I don't know, it just, you can kind of tell like the sense of community everyone has from it too. Like not only staying active, but having like that supportive network is nice.
Wow, that sounds amazing. I need to join this group. Yeah, that's great that it's getting at being able to have physical activity as an outlet, but also that supportive social network. That's great. Does anyone else have any good coping strategies to share? Abby shared in the chat that connecting with nature is a good way for her to cope with stress, and physical activity as well. Yeah, it's pretty great. I hope you all have good access to green spaces, or at least are able to get outside. I'm glad the weather is warming up. All right, so on this next slide, we'll just review a few things before we take the quiz. So the circumstances in which people live, learn, work, and play are also known as the social determinants of health. And the social determinants of health impact you from womb to grave, which is also called the life course perspective. And the three types of racism: institutionalized racism, interpersonal racism, and internalized racism, create differences in health outcomes known as health disparities. Chronic stress caused by racism, can also lead to allostatic load, early programming, and a change in genes known as epigenetics. So allostatic load, early programming, and a shift in genes caused by negative outside forces, epigenetics, can increase the risk of preterm birth, low birth weight, and infant and maternal mortality. All right, and then Gabby's gonna share the quiz for module 2 in the chat, and you all can let us know in the chat when you're done with that, and we'll move on.
So we're going to do our last session for the night. We're going to be going over sexual health topics. We're going to review how sexually transmitted infections, how sexually transmitted diseases are transmitted, how they're prevented as well as treated, It may get a little graphic. I was kind of debating whether I wanted to show the pictures of the sexually transmitted diseases and infections. They're a little graphic. I may post them just to wake everybody up, just in case you're falling asleep. But if it's too much for you, I'll definitely warn you before I get to the slides so you can, turn your head away or whatever you need to do. But I think I might just end up posting them. Yeah, so some of the objectives that we're going to go over is identify STIs that affect maternal and infant health, describe ways to prevent STIs, describe options for prevention and unintended pregnancy, and just get familiar with, how to talk about STIs and prevention and treatment. So it can get a little tricky talking about sexual health, especially, I grew up in Texas, and, it's just a very Republican state, and we don't talk about sex too much. We never really talked about it in schools. I didn't really get too much sex ed until I hit college, at least like the ins and outs. And so hopefully this presentation will kind of introduce you to some ideas that you've already seen. If not, educate you in these areas and help you to educate others and your peers when you're going through these presentations yourself. You can go to the next slide. So I'm just going to say a couple of key facts. I'm going to go through them a little bit quickly, but if you have any questions, you can pop them in the chat. So the first one is 15 to 24-year-olds represent 25% of the population, yet they account for nearly 50% of STIs. So sexually active adolescents and young adults are at higher risk for getting sexually transmitted infections. And that kind of goes back to the point I mentioned earlier. It's, because of lack of education, lack of sexual education programs in schools, et cetera, and conversations maybe not happening at home. Individuals with an STI are 2 to 5 times more likely to get HIV than uninfected individuals. The surest way to avoid STIs is to abstain from sexual intercourse or to be in a long-term monogamous relationship. Women ages 21 to 65 should have a pap test or a pap smear every 3 years, which is a screening procedure for cervical cancer. And then males and females ages 13 to 64 should be tested at least once for HIV. Okay, so these are a few terms that we're probably going to see throughout this part of the presentation. It's a lot. Some of these words I had never seen before. So if you have questions, you can pop them in the chat or you can unmute yourself and go ahead and ask. But, sometimes we have different words for these fancy medical words that we see here, but you'll see them throughout the presentation. So if you have any questions, just ask. Next slide. Okay, so we're going to define sex, which kind of, I would say in this generation is kind of hard because there's so many ways that we define it, but the few ways that are on this slide are vaginal sex, so a penis in a partner's vagina, anal sex, a penis in a partner's anus, oral sex, a penis in a partner's mouth, or the partner's mouth, or a tongue in a vagina. And then oral anal sex is one's partner's mouth or tongue on a partner's anus. Okay, so we're going to identify STIs. So STI is a sexually transmitted infection. Any infection that's transmitted through sexual contact. It can be caused by bacteria, a virus, a parasite. And really, if you're having unprotected sex, you're at risk for an STI. And you can still have an STI even if no symptoms are present. So that's why it's important to get tested frequently if you are sexually active. And so some viral STIs include HIV, AIDS, herpes, HPV, which HPV stands for human papilloma. Oh my gosh, it's always so hard for me to say that. Let's just call it HPV. Bacterial infections, chlamydia, gonorrhea, syphilis, and then parasitic trichomoniasis and pubic lice. Okay, so this is a little bit about HIV, stands for human immunodeficiency virus. So an American has 1 in 99 chance of being diagnosed with HIV at some point in time in their life. So every 9.5 minutes, somebody is infected with HIV. And if a woman is treated for HIV early in her pregnancy, the risk of transmitting HIV to her baby can be less than 1%. Okay. And so this graph is just kind of giving a layout of HIV and how it's kind of spread across the US. So you see, I can't zoom in because I'm not sharing the screen, but if you're looking at the map, you see like the areas towards the south have some of the higher rates of HIV infections. And, you know, some of the reasons that we talked about earlier in the presentation about, you know, these areas being, you know, traditionally South areas have more institutionalized racism because, you know, these areas, you know, if you think about, you know, back in history, the North and the South, you know, these areas are kind of more traditional, kind of more Republican. And, you know, you see, like because I'm from Texas, we have, you know, less sexual health programs and things like that in place. So someone put in the chat, said, the Bible Belt is also notorious for not providing appropriate sexual education. Definitely. And so that's definitely something that, you know, I saw being from Texas, you know, growing up in part of the Bible Belt. You know, I had so many peers, you know, I was in high school and, you know, I had 13-year-olds, 14-year-olds who were pregnant, you know, in my class with me in middle school. So it's definitely something that, you know, we see, that we've seen in the South traditionally. Okay, next slide. Okay, so it's just a little bit more about HIV symptoms. So many people don't have symptoms for years. So sometimes HIV, sometimes it takes about 10 years for the symptoms to present itself in someone's body. And some may develop a flu-like illness, fever, chills, rash, muscle aches, and sore throat. And so you'll see this maybe in the first couple of weeks of like the onset of the infection. So like when someone initially gets HIV, you may see, they may notice these flu-like symptoms, but usually it's overlooked because, you know, you think you just have the flu. And so that's why it kind of lays dormant in your body, and some people don't notice that they have it until, you know, years down the line. And so that's why, you know, the only way to know for sure that you have HIV is to get tested. And then also PrEP is something, I wouldn't say fairly new. I think it's been around since 2012, if I'm not mistaken. And it's FDA approved, and it's a drug that prevents the spread of HIV. So you can actually, you know, get prescribed this drug. I know there's a lot of companies that give the medication for free, as well as, you know, paying for, you know, if you're uninsured, they could pay for your doctor's visits. And you just take this medication as kind of like you would take birth control. You know, you take it consistently the same time every day, once a day, and it prevents you from getting HIV, but it doesn't prevent you from, you know, getting any other STI like chlamydia, gonorrhea, syphilis. So you should still also use you know, condoms and other barrier methods to reduce your risk of STIs as well as pregnancy. Okay, herpes. So herpes is transmitted from skin to skin, and also to mother to baby if you have an active outbreak in the moment. So it is less likely if you like, let's say you have herpes and you don't have an active outbreak and it's kind of just laying dormant in your body. It's less likely for it to transmit during vaginal births. But most of the time, at least I've seen, people getting C-sections, and recommending C-sections if you do have herpes, even if you don't have an active outbreak. And then some symptoms would include one or more sores, blisters, or pimples in the mouth or genital area. And there's no cure for herpes. I will make a note that there's herpes 1 and 2. So there's, herpes 1 that we see, in the form of like fever blisters, is what we call them, those bumps in the mouth area. And then there's herpes simplex virus 2, which is the one that you see in like the genital area where you see those outbreaks happening. Yeah, and so the antiviral drugs are available and they can reduce the frequency of outbreaks, which will help in just kind of managing that over time. Okay, this is one I couldn't say earlier. So HPV, human papilloma virus, there we go. So 20 million Americans are infected with HPV, 6 million new infections per year. 50% of sexually active men and women will become infected at some point in time in their lives. And so genital warts, it affects 1% of sexually active adults. And then for cervical cancer, 12,000 women get cervical cancer per year from HPV. And so, that's why it's important to get a pap smear if you're a woman every 3 years, so that you can catch these things early. And then also, using protection while you're having sex so that you can prevent this from occurring. And then there's vaccinations available as well. For the HPV vaccine for women, Gardasil also protects against genital warts, and then Gardasil is the only vaccine available for men, and it can protect against throat and anal cancer. I want to make one more note for this, is that you also can get pap smears for your anus as well, not just your vagina. So any area that you use for sex, you can have a pap smear done for. So in the same way that you get a pap smear done in your vagina, you would do that. You would do the same way for the anus if you're using it for sex. Okay. Chlamydia, so it's the most common STI in the US, and it's caused by bacteria. And so 1 in 20 sexually active females aged 14 to 24 have chlamydia. 50% of men and 75% of women who have chlamydia have no symptoms. But if you do have symptoms, some symptoms that women would see is bleeding after intercourse, between cycles, lower abdominal pain or burning pain during urination, abnormal vaginal discharge or itching. And then with men, there's fewer symptoms that they may see, but it may include pain or burning while urinating, discharge from penis, and then discomfort in testicles. And this is curable. So you take an oral antibiotic, and all partners should undergo treatment to prevent reinfection. So that part is really important. Okay, gonorrhea. So if I'm not mistaken, I think gonorrhea is number 2 most common STD in the US. So symptoms that women see kind of similar to chlamydia: pain and burning while urinating, yellowish or bloody discharge, pain during sex. And something important to note that if you leave it untreated, a pregnant mother can pass it to her baby. It can cause blindness in the baby. So it's definitely very important, especially because we're talking about, maternal health, noting, educating women in STIs and educating them in what we're going to talk about in a few minutes. Family planning will do wonders for, the maternal mortality rates. And, that's, I think someone mentioned it earlier, that's pretty much the key. It's one of the biggest keys in reducing maternal mortality rates and infant mortality rates is, educating the women in the various populations that are, disproportionately affected. Because if they have the tools, to make better decisions, make choices for themselves, they're more likely to do those things. You can go to the next slide. Okay, and then syphilis. So syphilis has 3 stages. Primary stage, you see some sores. There's a picture here that I will bring up the other presentation because it has a lot more graphic pictures. And this canker sore will last 3 to 6 weeks. Secondary stage, you can get a skin rash and lesions across the body. You'll see things like a fever, sore throat, headache, and those other symptoms associated with it. And then the last stage, it's associated with difficulty in coordinating muscle movements, paralysis, numbness, blindness, and dementia. And so at this point, you usually will know when you have syphilis because you see those sores, or if you get to that second stage, you're starting to have some symptoms. I know getting to the third stage is it's really dramatic. So because there is treatment for it, it's very important that, we're aware of these stages so that we know how to diagnose it, or really we know at least to go to a doctor or get tested somewhere so that they can diagnose it. But it is curable with antibiotics, with the penicillin shot actually. It can cause damage to internal organs in late stages, is irreversible. So early detection is key. This is trichomoniasis. This is a parasitic STI. So symptoms in women, frothy yellow-green vaginal discharge, strong odor, and then kind of some similar symptoms as the others, burning during intercourse, urination. Pregnant women may experience preterm delivery, so that's also important to note. And then in men, mild irritation around inside the penis, discharge, and then burning during urination and ejaculation. But again, it is also curable with antibiotics. So this is kind of a keynote in a lot of these STIs that we've mentioned, besides HPV, herpes, and HIV. A lot of these are curable. If if you're detecting them early, even better. You get to skip all the nasty symptoms or prolonged symptoms, but they are curable for the most part. Okay. This is pubic lice and scabies. I know, gross. So this is parasitic. So pubic lice, it's a parasitic insect that can be found attached to the hair in the pubic area, but sometimes they're found on coarse hair elsewhere around the body. And then scabies, they burrow below the skin and leave tracks behind them, and they can be found in creased areas in the bodies like fingers, toes, and arms. And then the treatment, they're best treated with a wash containing permethrin. Sorry. Okay, so the difference between STIs and STDs, so I was kind of interchanging them earlier, but STDs are sexually transmitted diseases, and then sexually transmitted infections is a STI. And so it's more widely used term because it eliminates some of the stigma around the word STD. And so the difference is not all STIs turn into STDs. So like, for example, common STIs that turn to STDs, HPV to cervical cancer, HIV turns to AIDS. And so I think those are the only two that turn to STDs, but the rest of them, from my knowledge, are known as STIs. Okay, so now we're gonna go pretty quick through these last barrier methods. I know we have just a few minutes left and I wanna leave room for anyone's questions. These are a few barrier methods that you can use when you're having sex. So we have the male condom, the female condom, contraceptive sponge, spermicide, diaphragm, and a cervical cap. And so I'll go over those, just a little bit about each one of those. So we know, a male condom, you've probably seen them around, how to use them. You take the condom out of the wrapper, you make sure there's not any tears or holes, because if you do see those, it's ineffective. We want to place the condom on the head of an erect penis, and then pinch the tip to leave room for cum, and then you'll roll the condom down on the penis, and then of course you remove the condom after sex, hold it at the base of the penis when you're pulling it out. And then condoms have a right and a wrong side. So the right side out, the condom should look like a small hat with a ring on the outside. And if you realize that you've put the condom on the wrong way, like inside out, then just throw it away and put on a new condom. And for the female condom, it's a pouch placed inside of the vagina or anus, so you can use it also for anal sex. And similar to male condoms, it catches semen. And then how you would use this is that just like the male condoms, you want to make sure there's no tears. You'll squeeze the ring, because there's a ring on the inside of the condom. You'll squeeze the ring and you'll push it inside, or insert it inside the vagina as far as it'll go. It should reach the back of the cervix. And then you just adjust the end of the condom, because it's supposed to cover the vaginal area. So sometimes you have to hold it into place. So it's a little bit, in my opinion, less effective than a male condom, but it's more so as a female empowerment tool. If the male that you're having sex with doesn't want to use a condom, you have something also to protect yourself with. And then the contraceptive sponge is a small sponge containing spermicide that can be inserted into the vagina before intercourse, covering your cervix. Contraceptive sponges do not protect against STDs. So I actually haven't seen too much of contraceptive sponges out on the market. I don't know if anyone else has seen them, like at CVS or Walgreens, but I haven't seen them. Spermicide, so it's a chemical, usually like a cream or a gel that you place in the vagina before sex to slow the sperm and prevent them from reaching the egg and, preventing fertilization, thus preventing pregnancy. But this as well does not protect against STDs. And then the diaphragm is a small cup inserted inside the vagina before sex that catches sperm and covers the cervix. And again, like all of the rest, they don't protect against STIs. And then the cervical cap, it's a soft cup that covers the cervix to prevent pregnancy as well. You can go to the next slide. Okay. These are some hormonal methods. So injectable contraception, the shot, oral contraception, the pill, the patch, and then the vaginal ring. So if you've ever been on birth control, you've probably weighed your options to see which one, won't make you the most sick, or maybe you want to skip your period or whatever the case. But these are a few of the hormonal methods. And we'll go to the next slide. These are more of the long-acting reversible contraception. So we have the IUD, the intrauterine device that goes inside of the vagina into the back of the uterus, and it releases hormones, although there is a hormone-free option that exists. That's the copper IUD. And then they can stay inside of your uterus it ranges depending on the one you get, 3, 5, 7, 10 years. And then there's the implant that's like a matchstick size rod that goes into your upper arm. And it protects against pregnancy for up to 3 years, but none of these protect against STIs or STDs. And then again, the IUD. So these are emergency contraception. So you can use the IUD as an emergency contraception when inserted within 5 days of unprotected sex. So they are the most effective form of emergency contraception. And then, of course, Plan B. Pills like Plan B are the morning after pill when taken after unprotected sex. They can prevent pregnancy. And then the effectiveness does, it does have a window of effectiveness. I believe it's like up to 72 hours after sex with an 89% effectiveness rate. If you take, and then if you take the Plan B within 24 hours, the effectiveness rate is 95%. Next slide. Okay, and so these are sterilization, natural methods. Well, these are some of the sterilization and natural methods that you can take for birth control. So tube ligation, this is, getting your tubes tied. And so this, of course, is, with your fallopian tubes, it's a surgical procedure that blocks the eggs from traveling through the fallopian tubes and blocks the sperm from reaching the egg. And it's mostly irreversible, and attempting to reverse it is a major surgery that's not always very effective. So you definitely want to make sure that when you do it, you're ready for that decision. And then a vasectomy, it's a snip. So it's a surgical procedure that blocks sperm from leaving the testicles. And vasectomies are meant to be irreversible as well. And then these are some of the natural methods, pulling out, lactational method, which is like when you're pregnant and you're breastfeeding. If you breastfeed consistently, let me see, I forget how this method is. If you're breastfeeding, sorry, I'm trying to look for some notes on that. So I'm not too familiar with it. I've never had a baby, so I've never breastfed.
I think exclusively.
What was that?
Exclusively.
Right, yeah, you're exclusively breastfeeding. I know this is a form, it's a pretty effective form from what I've heard of a contraceptive. Yeah, if you have any questions about that towards the end, we can talk about it. I just am not able to find my notes on that. And then fertility awareness, this is, using your ovulation calendar. So, tracking your menstrual cycle from, day 1 to day 35 or 30 or whenever it ends. And so these methods are a little bit more riskier. You really have to know your body, trust your partner, etc. If you want, a very effective form of birth control, it's recommended that you use like the hormone, the pill, the patch, the IUD, methods like that. They're more secure. These are more, natural methods, but there is some, some varying on that. Next slide. Okay. And this is just showing again all of the contraceptives that we talked about, and kind of just showing their effectiveness. I know that at the very top, the more effective ones are going to be the IUD, and then of course if you get a vasectomy, get your tubes tied, the implant. I know there's some research recently about the pills kind of going up in their effectiveness. Of course, if you're taking them every day, which, when you factor in human behavior and having to remember to take those things, it could always mess up the effectiveness. So if you want something that you don't have to think about, that's why these ones are the most effective, the ones towards the top. Yeah, I think that's that might be our last slide. Yeah, that wraps up contraceptives, sexual health. Does anyone have any questions? There's not a quiz over this area. It's just a perk, and it's definitely important for for women to have these tools, so that, you know, they have a sense of empowerment over their bodies, and they're able to control, you know, whether, you know, they want to have multiple children, whether they want to work and, you know, maybe increase the income for their family. So it's important for women to have access to this kind of knowledge over their bodies, so that they're able to make decisions that, you know, that are in the best interest of their family, as well as, you know, as well as their own bodies. Any questions on that or anything that we've gone over today? I think we just hit the time, so we did great on time.
I just wanted to say, very informative. Great.
Awesome. Thank you. And thank you, ladies, for joining and participating through the chat and the discussion post that we posted throughout the presentation. It's always more fun when we have some interaction. So thank you for interacting.
Okay, so module 3 is on preconception health, excuse me. Next slide. So just to go over the objectives, we're going to discuss infant mortality, maternal mortality, and preterm birth rates in the U.S. We'll discuss some of the health disparities related to infant and maternal mortality and preterm birth. We'll understand what prenatal care is, understand the aspects of preconception health, and understand life planning. Next slide. So just to start and to go over a few key facts, in the United States, nearly 6 out of 1,000 babies die before their first birthday every year, and non-Hispanic, Black, and American Indian, Alaskan Native infants die at much higher rates than non-Hispanic white infants, and Black infants in the US are more than twice as likely to die as white infants. In the US, the preterm birth rate among Black women is 49% higher than the rate among all other women. And for African American and minority women, chronic stress can lead to many health problems for both the mother and the baby during pregnancy and after birth. And then half of all pregnancies in the US are unplanned. Next slide. So this slide is just looking at the worldwide infant mortality rates. And as you can see, among, I believe these are all considered developed nations, the United States has a much higher rate than any of the other nations here. And a leading cause of infant mortality is preterm birth, and this rate has been rising significantly in the last decade. Some of the other leading causes of infant mortality include low birth weight, birth defects to the heart, brain, and other major organs, and sudden infant death syndrome, which is when a baby dies during sleep from unknown causes. Next slide. This slide is looking at the worldwide maternal mortality rate among developed countries, and once again, the US is significantly higher than the other countries here. It's actually pretty astonishing. The maternal mortality basically means the death of a woman while pregnant or within 42 days of termination of pregnancy from any cause related to or happened because of the pregnancy. And this can be either accidental or incidental causes. This slide just kind of highlights some of the disparities in birth outcomes, and these stats can tell us a lot about what's happening in the American healthcare system, but it's not really the whole story. Because of the burden of infant and maternal mortality is not equally shared in the United States, and it's much higher for African American babies and mothers. And these differences can often be linked in part to poverty and other disparities in educational achievement, but that's only part of the picture. Racism also plays a large role in who is sick and who is well in these infant and maternal mortality rates in this country. So these are just, I think, a few headlines from the news in recent years. The New York Times is calling it a crisis in our nation. A lot of you probably heard about the incident with Serena Williams, where she had, I actually don't know a ton about it, but I believe she had to insist on getting a CT scan during her pregnancy. Otherwise, she could have died, and the doctors were just gonna kind of ignore her because of her race. Next slide. This slide looks at the disparities in the US in infant mortality rates, and kind of showing the different races and rates at which they die per 1,000 live births in 2016. So African American and American Indian and Alaskan Natives have the highest rates of infant mortality, and African American infants die at more than twice the rate of non-Hispanic white infants. In many instances, these infant deaths are caused by the health impacts that disproportionately impact African American and minority communities, and these include low birth weight, so usually babies born weighing less than 5.5 pounds, preterm birth, babies born before 37 weeks, and then sudden infant death syndrome when babies die during sleep because of unknown causes. The next slide looks at the disparity in US maternal mortality rates by race, and African American mothers die during pregnancy nearly 3 times the rate of white mothers. And then the next slide is looking at the disparity in preterm birth rates. So across the country, Black women are 49% more likely to deliver preterm compared to white women. American Indian and Alaskan Native women are 18% more likely to deliver preterm compared to white women. And in addition to being one of the leading causes of infant mortality, preterm birth is also linked to increased risk for heart disease later in life for the mother. So these issues, you know, it's a big issue. Preterm birth is a big issue for the mother as well as the child. The next slide is on rethinking birth outcomes, trying to understand why there are such disparities in birth outcomes, and a lot of it comes down to the social determinants of health, the life course, to chronic stress, and other health disparities. So next we'll talk about what we can do about this. One method to tackling these disparities is to focus on prenatal care. And this is typically preventative care when a mother gets routine checkups from a doctor, a nurse, or a midwife during pregnancy to monitor the baby's development and prevent any health issues for both the mother and the baby. Babies of mothers who do not get prenatal care are 3 times more likely to have a low birth weight and 5 times more likely to die than those born to mothers who do get care. And prenatal care should begin as soon as a woman finds out she's pregnant. So this slide is looking at the critical periods for development of prenatal care. So birth defects of the brain and spine tend to happen in the very early stages of pregnancy, often before a woman even knows she's pregnant. So in this graph, you can see that the time period when women enter into prenatal care is usually far past the critical periods of development for most of the baby's body parts, including its heart, arms, and eyes. And compared to white women, minorities either get prenatal care too late or not at all. And vulnerability to preterm delivery may be traced not only to the exposure to stress and infection during pregnancy, but response to stress and infections patterned over the life course. So what is preconception care? It is caring for your physical and mental health now, even if you aren't planning to have a baby anytime soon, or even know if you ever want to. And it's important because good health habits protect your health now and guard against the health disparities in the future. Preconception health begins long before a person thinks about becoming pregnant, and since half of all pregnancies in the US are unplanned, helping all young people take better care of their physical and mental health can help reduce the cycle of infant mortality over time. So in terms of what to do to help with your health, eat more fruits and vegetables, cereals and grains that contain folic acid and other and help others do the same. This is super important, as well as developing social networks that support physical activity and having fun, establishing support networks that encourage controlled alcohol, cigarette, and other drug use, and asking friends and relatives to be your healthcare advocates and offer to do that for someone else as well. The next slide focuses on mental health. Chronic stress and limited accessibility to resources can also lead to mental health impacts, and African Americans are more likely to report having serious psychological distress than non-Hispanic whites. And identifying and limiting behaviors and exposures that negatively impact mental health can contribute to preconception health and improve quality of life. So strengthening interpersonal relationships is one of the best ways to do this. The next slide is about coping with mental health challenges. Men and women who could be experiencing depression or anxiety are often encouraged to monitor their mental health and be prepared for moments that can trigger symptoms. So establishing a mental health and emotional health routine that you can practice every day is really beneficial. So this can include maintaining a good diet and exercise plan, establishing a time management plan that makes room for rest, sleep, and hobbies, investing in a spiritual or religious practice, paying attention to your thoughts, also known as mindfulness, and monitoring the ways you allow yourself to react to negative emotions. And then overcoming the stigma of mental health by becoming educated on the subject and sharing information with friends and family and on-campus support groups is very important as well. And having an action plan in place to respond to triggering events is also a good idea. This can include establishing coping mechanisms to address immediate needs, such as breathing techniques, identifying a trusted person to turn to, whether it be a family member, friend, or a teacher who's willing and able to set aside time to help, and identifying free and local resources on campus or in the community, such as counseling services, peer support groups, or hotlines and forums. The next slide is just a quick overview on intimate partner violence. Intimate partner violence is another factor that can affect mental health, and paying attention to your relationships with others and making sure that they are healthy relationships is another way to monitor and maintain good mental health. But interpartner violence does not just affect mental health, it can also include emotional, psychological, economic abuse, or other forms of physical abuse as well. So this graphic here is just showing the different ways that intimate partner violence can impact you. Next slide, please. Looking at some of the stats, nearly 3 in 10 women, about 29%, and 1 in 10 men, 10% in the US have experienced physical violence and or stalking by a partner. And abuse can occur on a spectrum, and it's important as a peer health educator to have the ability to identify when abuse is occurring and know how to address it. We'll skip this activity and move on to some of the coping with intimate partner violence. So now that we know how to identify the different types of abuse across the spectrum, it's important to know how to address intimate partner violence. So here's some techniques that can be used. You can refrain from confronting the abuser, assure the victim that he or she is not the cause of the violence, be prepared for the victim to minimize the violence or deny abuse, help the victim identify his or her own resources and strengths, and discuss a safety plan and resource available to the victim, like on-campus services, peer support groups, and legal support and financial assistance for relocation. Sexual health. So this is what we went over last week in the sexual health module, so we'll skip through that and move on to life planning. So as we've mentioned, about 50% of pregnancies are unplanned, and unintended pregnancies can cause emotional distress, financial pressure, strain on relationships, and can affect a young person's ability to achieve their life goals. So if you are not planning on conceiving in the near future, identifying birth control options is an important step to take, and consider choosing a birth control method based on how well it works and how well it works for you. So some things to keep in mind are how easy it is to use, how much it costs, the health conditions or other medication that could interfere with its effectiveness, and be sure to use methods that prevent both STDs and unwanted pregnancies. So I believe that we went over these types of birth control last time, so we won't go through those again unless anyone has any questions. We will skip the life plan workshop, and that leads us to the quiz.
Okay, we can go over the module 3 quiz answers now and the module 4 quiz answers after module 4. And we forgot to go over the answers for module 1 and 2 from the previous session. So maybe we could go over those at the very end before the post-test. Okay, so I have the answers up on the for the module 3 quiz, so I can just go over those really quick. So for question number 1, in the United States, nearly blank out of 1,000 babies die before their first birthday. That answer is 6. So 6 out of 1,000 babies die before their first birthday. And then number 2, maternal mortality in the US continues to rise. Number 3, African American infants die at more than twice the rate of non-Hispanic white infants. And true or false, across the country, Black women are 25% more likely to deliver preterm compared to white women. That is false. So Black women are, I believe, 49% more likely, if I'm correct me if I'm wrong.
That sounds right.
And then for number 5, babies of mothers who do not get prenatal care are 3 times more likely to have low birth weight. And then, excuse me, number 6, prenatal care should begin as soon as a woman finds out she's pregnant. And then 7, true or false, chronic stress and limited accessibility to resources can also lead to mental health impacts. That is true. And intimate partner violence can include all of the above: economic abuse, psychological abuse, and physical abuse. And for number 9, 50% of pregnancies are unplanned in the United States specifically. And then the last question, number 10, which type of birth control is least likely to prevent pregnancy? And the answer to that is the rhythm method. So I don't know if we specifically covered that, but that was in the sexual health module. If you want to learn more about sexual health and you weren't at the first session, then you can view the recording for that. All right. Great job.
All right, thanks. We'll move to module 4. Okay.
All right, so module 4, organizing for implementation, will just be covering what it's like to create and maintain PHE clubs on college campuses. Next slide. All right, so the objectives are to understand the connection between the social determinants of health and community resources, learning how to grow and maintain PHE programs on college campuses, understanding how to identify key areas of need among peer groups, and learning how to plan and implement projects on campus. Okay, so now that you guys have a better understanding of the social determinants of health, the life course model, and preconception health, it's important to share these topics with others on campus. A system driven by institutionalized racism is a system of repetition. And as a peer health educator, you now have the power to help stop this cycle. Next slide. All right, so creating a sustainable program. Activism isn't a one-man or a one-woman job. To make tangible change, you'll need a dedicated team of peers for support. And so there are three main components to creating a sustainable PHE program. The first being establishing PHE program. That's all about determining your leadership, creating your exec board, identifying your president, your VP, secretary, social media manager, etc. The second one is networking. It's important to meet with faculty and staff interested in supporting the program and coming up with your mission, your vision, and the activities for the coming year. It's also important to meet with administration to explain the PHE program, its intended outcomes, and the types of activities you'd like to implement on campus. For any club, getting buy-in from admin at the beginning of the program is really important, as it's vital to program success and sustainability. And if it's not an already organized student organization, it's important to meet with the school student government and apply to become a campus org. This is especially important just because it can provide the program with some additional funding and allow you to partner with other campus organizations. And so lastly, you can use outreach events to grow the program by recruited, interested participants and members. Now, the third step is communicating. You can publish an article about the program in the school's newspaper or on the school's website. I know that we rely a lot on Dornsife Dash to do this. If not already active, you can develop a website or other social media outreach tools to keep members up to date on any events and meetings that have been going on. You can consider having members write short articles on health topics or repost information about the social determinants of health, the life course model, and preconception health. I know that we try to keep up to date with any national health awareness campaign that's going on. So be sure to follow our Instagram page. Quick plug there. So if anyone could drop our name of the Instagram page, that'd be great. Lastly, you can set up a digital newsletter and exchange that with other PHE programs across the country to share updates and develop partnerships and relationships, and maybe give each other ideas on programs and projects you could be implementing. Next slide. All right, so being a peer health educator. On-campus activism involves establishing a way to systematically look at a situation, map out your available resources, set your priorities, and create an action plan. And so being a peer health educator can be broken down into the 4 steps: assess, map, prioritize, and act. Next slide. Thanks. All right, so assess. You need to identify subject areas to address on your campus, discuss areas of needed attention among your fellow PHEs. You can conduct an on-campus survey, kind of like a needs assessment to identify topics. And this is also a great opportunity to recruit new members to the club. And then potential subject areas can include sexual health and protection, mental health, intimate partner violence, and where to find and access for on-campus resources. Next slide. All right, map. It's important to map out available resources, including partner organizations, access to materials, and relationships with influential people and faculty on campus. You need to be prepared by developing a systematic plan for accessing and engaging with each resource before an event or meeting. And some available resources could include access to materials and spaces to host meetings and events, Again, relationships with influential people and faculty on campus or professionals in the Philly area, and relationships with partner organizations. All right, prioritize. Again, you need to identify which subject areas require the most immediate attention among peers, or what's resonating most with individuals and club members. And that can be, sexual health, chronic stress due to racism, preventative measures. You need to make note of priority areas you want to focus on and the necessary resources to take action and produce successful results. So you can brainstorm possible responses to each priority area, or create a hierarchy of projects and a corresponding timeline to keep members on track and set expectations. All right, act. So for any club, again, it's important to keep in contact and send updates via email, social media, or in-person outreach to partners and participants beforehand in order to maintain high attendance numbers. Again, need to organize all your necessary on-hand resources, establish your exec board, your member roles, and set measurable goals for each event. That could be attendance, knowledge of the key messages you want participants to be taken away from any event that you're hosting, or program growth, again, through new members. And so, again, it's important to document key information during each event, like, again, the number of attendees, who's participating, brief summaries of what's being discussed, and using this information to improve future events or replicate what's working well. And so setting goals for yourself and recording data is an important step to ensuring the steps being taken and efforts being applied are effective and helpful. Next slide. All right, guys, now it's time for Module 4 quiz. And again, just let us know when you're done in the chat. All right, so I see that you're both done. I can go over the question. So number 1, true or false, to make tangible change, you can be a one-woman or one-man team. False. Number 2, being a peer health educator can be broken down into 4 steps, which include all the following except practice. So it does include map, assess, and act. Number 3, subject areas to address on your campus could include all of the above: mental health, intimate partner violence. Number 4, be prepared by developing a systematic plan for accessing and engaging with each resource before an event or meeting. Number 5, when identifying subject area to address on campus, peer educators should identify subject areas that require the most immediate attention among peers. Number 6, what is one of the best methods to engage with other PHE programs across college campuses? Establishing a digital newsletter. Number 7, true or false, you should set non-measurable goals for each event. False. Number 8, which key information should you document during each event? All of the above. Which members participated, a brief summary, what was talked about, and number of attendees. Number 9, true or false, in order to create a sustainable PHE program, you should determine leadership roles among members. True. And number 10, setting goals and recording data is an important step in ensuring that the steps being taken and efforts being applied are effective. All right, great job. So module 1, let's see, the first question, true or false, education is often correlated with health outcomes. True. Number 2, which wealthy country has the highest rate of infant mortality? United States. Number 3, true or false, immigrant groups' health improves the longer they live in the United States? False. Why was the Office of Minority Health created? To address health disparities. What does infant mortality mean? The death of children younger than 1 year old. What is a key trait of a peer educator? Transparency, true or false, storytelling, active listening, and public speaking are good methods of communication when communicating a topic. True. Research shows that people are more likely to accept information and thus change their attitudes and beliefs if they feel like the message is similar to them or has gone, if they feel like the messenger, is similar to them or has gone through the same life experiences. What score is needed on the post-test to be awarded a level 1 training certificate? 75. And how many attempts do you get to be awarded certification? It should be 3 in total, and if you don't pass the first time around, you have 2 more attempts.
Great, so now I'll go through the module 2 quiz. True or false, for many health conditions, non-Hispanic Blacks bear disproportionate burden of disease, injury, death, and disability. This is true. Blank in their 20s, 30s, and 40s are more likely to live with or die from health conditions that typically occur at older ages in whites. The correct answer is African Americans. What is the main idea of the social determinants of health? These are biological, psychological, and social factors that play a large role in determining health outcomes. True or false, the 3 main types of racism talked about were internalized, externalized, and institutionalized racism. This is false. Institutional barriers have occurred in all of the above: government, education, and housing. Which of the following is a main idea of the life course perspective? Health outcomes are the result of biological, social, and psychosocial factors accumulating over a lifetime. Allostatic load is the idea that chronic stress can lead to long-term health impacts. Epigenetics show us that past traumas can be recorded on genes and passed on. Chronic stress can impact all of the above: low birth weight, hypertension, and mental health disorders. And then lastly, chronic stress can be managed by creating a safe place within your community. So does anyone have any questions about any of the module material before we move on to the post quiz? Awesome, so we will send out the link for the post test now. You guys can do that, and I think we'll probably take a look at that. I guess we'll go over the answers again now and then take a look at the answers and let you guys know if you passed or not, and then we'll also have a post-test survey to complete as well.